Hi, I'm Kyle Harrison, and this is the Symptomatic Bradycardia module for the ACLS and CRM iPad app. So let's get started. So let's define what we mean by symptomatic bradycardia. Well, let's first just define bradycardia. So bradycardia or bradydysrhythmia is basically any rhythm with a heart rate less than 60 beats per minute. Now, it could be sinus bradycardia, so it's a sinus rhythm, or it could be a high degree nodal block. Could be first, second, or third degree heart block. The thing that quantifies it as bradycardia is less than 60. Now, symptomatic bradycardia, that's when you have signs or symptoms that are secondary to the slow rate. So basically, you're symptomatic. So what are some of the symptoms that you can have from this slow heart rate? And it's really a low cardiac output that's resulting in this symptomatology. So you could have hypotension, you could have altered mental status, pre-syncope, syncope, even loss of consciousness. You can have shortness of breath as the heart goes into failure. You could also have shortness of breath from the body basically trying to drive the low output, trying to get more oxygen delivery to the periphery. And then obviously you can have congestive heart failures from the slow rate. Typically, as you get into the 30s, the heart starts failing because you have such a very long fill time that the heart starts dilating. But that may be right shifted for people with poor EF. So you can go to heart failure at even a higher rate if you have pre-existing heart disease. So there's not an absolute number, is what I'm basically trying to say. A young healthy person likely will tolerate a heart rate down in the 40s, maybe into the 30s without any symptoms, whereas a person who is in heart failure and needing all that heart rate to generate an adequate cardiac output due to decreased stroke volume or decreased EF, maybe 70 would be too low for them to maintain adequate perfusion. But in general, an average patient, they're not going to be symptomatic unless the heart rate is less than 50 beats per minute. So how do you treat it? So the first thing you want to do is always confirm that the patient actually has a pulse. If the patient is pulseless, then you're going to proceed with the PEA algorithm that supersedes all other treatment because a pulseless patient requires CPR, and please review the PEA systole algorithm, module for that. So once you've assessed the pulse, then you want to make sure the patient has an adequate airway and they're breathing. Obviously, the patient is hypoxemic or near apneic or even apneic. Bradycardia may be a sign of hypoxemia, so you want to assist the ventilation. If they're adequately ventilating, then you want to provide 100% oxygen because this is a critically ill period, so you want to support the oxygenation, and you want to check the blood pressure to try and assess what kind of perfusion the patient has. In the meantime, you'll also be doing a quick assessment of other signs and symptoms to try and decide, is this symptomatic or not. Assuming that it's symptomatic, then you'll proceed with the treatment protocol. So you're going to have to establish IV access because this is most of the pharmacological interventions need to be given intravenously. As you start treating, you can start searching for some of the possible etiologies of this. Is this from drug overdose, a beta blocker, calcium channel blocker? Is this patient having an interferon wall MI? Is this patient have a conduction abnormality that is that it was not known to you? There are many different reasons. You want to try and rule some of these out, treat them as possible, but you're also going to be treating the patient while you look for these causes. So go ahead and call for the crash cart. The crash cart is going to bring resources. It's also going to give you the ability to do transcutaneous pacing, which is in the algorithm. And you should know that most defibrillators also have the pacemaker feature associated with it. Now, these are the ones that are on crash carts. AEDs obviously don't have pacemaker function, so you're going to need to get a real pacer defibrillator. Once again, check your local hospital to know what is available for you. This would be part of knowing your environment. So the first line drug first line intervention is going to be atropine. So you're going to start with 0.5 milligram IV bolus. You don't want to give less because giving less, usually like less than a quarter of a milligram, can actually maybe cause paroxysmal slowing. So you want to actually make sure you give at least 0.5 milligram. And this can be repeated every 3 to 5 minutes up to a maximum dose of 3 milligrams. You basically get no more mileage above 3 milligrams, so stop at that. You should expect a slow circulation time. A very slow heart rate is going to take a while to circulate this drug, so you may not want to stack doses, but you do need to escalate the dose if you're not seeing an effect. And it's important that if your first-line agent, atropine, fails, or the patient is very symptomatic, then you may need to proceed straight to transcutaneous pacing as you administer the drug. Atropine is usually available on most crash carts, so it should be readily, easily to administer, but don't delay transcutaneous pacing, at least initially, until you can get some drugs into the patient. So you try the atropine, and some things you need to know about atropine. It may worsen ischemia in patients experiencing ischemia or myocardial infarction as you increase the heart rate. That's obviously going to increase demand. Atropine is less likely to be effective and may not be effective at all in a second-degree AV block type 2 or in a third-degree AV block. So you may want to just jump straight to transcutaneous pacing. However, it doesn't hurt to try. And then it's important to note that a third-degree heart block with a wide complex QRS is a very unstable rhythm. These patients are very much at risk for going to asystole because basically in a third-degree heart block, you're getting no conduction down the normal conduction pathway, and as the QRS widens, then you're getting ventricular escape rhythms, usually in the 40s, and these ventricular escape rhythms are not a very stable pacemaking. There's not a very stable pacemaker in the ventricle, so at any moment it could just give out, which would then put the patient in the asystolic algorithm, which is the same as a PEA, and then you would proceed with compressions and down that road. But hopefully you can intervene before you get to that point. So if atropine fails to increase the rate, then your next selection is either you're going to select infusions, which are dopamine or epinephrine, or transcutaneous pacing. And you may have to start with transcutaneous pacing as you wait for the infusions to come, or you may be able to just treat with transcutaneous pacing. It's important to proceed with immediate transcutaneous pacing for any unstable patient without IV access, because you can't administer atropine or these infusions except by IV or IO access. And you need to know that infusions may take some time, so you may need to bridge, as I said, with transcutaneous pacing. So let's talk about transcutaneous pacing here. So it's important when you hook up the transcutaneous pacer that you need to know that there's two different adjustments that need to be made. The pacer has a rate, which is the amount of how frequent it sends its stimulus out. And if you get capture, that's going to relate to the heart rate that you get. And then it has its output, or amount of energy that's sent out from the pacemaker. So it's important that you know how to adjust both of these, because if you have the rate set to 0, no matter how much output you put, you're not going to get capture. And conversely, if you have the rate set appropriately to 60 or 70 and you never turn on the output, then you're not going to get capture. So both of them need to be modified depending on what the preset settings of the pacer are. So first thing to do is confirm that it's set for 60 beats per minute. That's adequate. You can then move up that depending on what kind of output you need. It's going to be basically a fixed stroke volume, so increasing the rate will increase the blood pressure, but start with 60. And then what you can do with a patient that has a pulse, because the only time they're going to be using this is with the patient with a pulse, no longer indicated for asystolic patients. You're going to increase the amplitude, the milliamps from your output. So you're going to go starting at 0 and then start increasing until you see capture on the monitor. And how are you going to know that you have capture? Well, you're going to see a pacer spike, which is a single spike, and then you will see a deflection of the ventricle, which is opposite of the direction of the pacer spike. As you start increasing the milliamps, you'll start seeing pacer spikes, but you won't see that negative deflection after each pacer spike until you get capture. Other signs of capture, obviously, you're going to have the rate should be what you set. So if you see the rate is 40 and you set it for 60, you're not getting capture. You get to 60 and you see a negative deflection after each pacer spike, then you know you've got capture. Now that's important to note that that's electrical capture. The next thing you need to know is that you have mechanical capture. And what I mean by that is that you actually have a cardiac output with that. So you need to do a pulse check to make sure that you're actually getting the output that you think you are. Just because the EKG shows capture doesn't mean the actual patient's having ejection with that. So confirm that with the pulse check. Once you've achieved electrical and mechanical capture, then you need to set your output for about 2 milliamps above threshold. The reason for this is that you want to make sure that you don't dip below what the pacing threshold is. So if you find a mechanical and electrical capture at 80 milliamps, then you want to go to 82 milliamps, maybe 85. But you don't want to go much higher than the desired amount to reach capture because this energy is uncomfortable. It does cause discomfort for the patient. So you want to be at the minimum amount to get capture, but not right at that threshold because things may change and then you'll lose capture. And so that means you need to continuously monitor for failure to capture. If this starts failing, then you're going to be back to where you started. So continuously assess that. Maybe you'll want to place an arterial line as you wait for more definitive therapy so you can have a better assessment of the beat-to-beat cardiovascular status of this patient. Now, it is important to note that transcutaneous pacing is uncomfortable for the majority of patients. Causes muscle contraction, causes a shocking-like sensation. It's not dangerous, but it is uncomfortable. About 80% of people rate it as moderate to severe pain. So you may need to sedate the patient that is receiving transcutaneous pacing. However, you may need to start pacing before you can adequately sedate the patient. So stability precedes sedation. Once you've been able to achieve capture, then you can cautiously either give an IV narcotic or benzodiazepine, monitoring for underlying physiologic response to those drugs. You don't want to tip them over if they're just barely perfusing. And then options are to try and add a pharmacologic agent that's not uncomfortable for the patient. So get capture, then you have time to get the infusion set, switch to either dopamine or an epinephrine infusion if possible. And then you need to plan for emergent placement of a transvenous pacemaker. Contact your cardiology consultant, maybe your intensive care physician can help you with this, but you need to move towards getting a little more stable access, a little more stable pacing abilities than you can just get with the transcutaneous pacemaker. It's not a permanent pacemaker, but it will pace more effectively than the transcutaneous pacemaking. The transvenous pacer is, that is. So let's look at this. This is the pacemaker that we have here at Stanford. It's part of the defibrillator. Important to note that you need to hook up both the EKG leads with the defibrillator pacemaker and the pads. And the reason for that is that the pacer pads can either send or receive energy, but it can't do both, meaning that it can send out electrical energy to pace, but that means you can't interpret the rhythm. Therefore, if you're using the defibrillator as your monitor, you're not going to see if you're getting capture. And more importantly, most of these pacers have the ability to inhibit if the patient's intrinsic rhythm competes or is restored. So you want to hook up the leads so that if the patient starts competing with the pacemaker, you won't get an RRT phenomenon. So both are important to hook up, and you see here the leads and the pads. Obviously, you can follow they're labeled front and back to place on the patient. Now, as we talked about before, there's two different two different dials that you need to select when you select the pacer. So in this monitor, you would turn the center knob to pacer, and then you would set the rate for at least 60 beats per minute, and then you would increase the milliamps up. The pacer output is there on the left, and pacer output. So here you see the pacer is set for 70 beats per minute, but there is 0 milliamps. So this is set to 0, so you need to change the pacer output, increasing the milliamps until you get capture. So infusions, these are equally effective as pacing. So the two that you will most likely select to help with the heart rate is dopamine in the chronotropic range, 2 to 10 mics per kilo per minute, and or epinephrine, 2 to 10 mics per minute. This is not weight based. This is just 2 to 10 mics per minute. Dopamine is going to be easy to get. Mostly it's pre-mixed and should be easily found in crash carts or on wards. Epinephrine needs to be diluted, so it may be a little harder to get. But if you have a pharmacist on your co-team, then you can get them to mix that quickly. And it's important that you always use a controlled infusion device. And what I mean by this is you don't just drip this in. You need to be able to set these rates specifically, and so you need to use actual control infusion device, whatever your hospital uses. Follow up. Unless the underlying cause is found and treated, the patient will likely need emergent pacemaker placement. And once again, this will be transvenous, so you need to prepare for that. And you need to understand these patients are high risk for further decompensation. So continuous monitoring is required. These patients should be in an intensive care setting until they have permanent pacer access. And you need to try and figure out what caused the bradydysrhythmia. Is this an MI where you need to go to the cath lab for both a pacer as well as a percutaneous coronary intervention? Is it drug overdose, which you may be able to treat with antidote, etc. So you need to figure out why the patient is having this bradydysrhythmia. So that's the end of this symptomatic bradycardia lecture. Thank you very much.